So, Carol, I know this is your specialty, so I really want to set you up to talk a bit about this. But what we're talking about right now, about the narrative that we create and our mind being a chatterbox nonstop, it just chatters, not much of which matters. I'm Dr. Tom, psychiatrist, specialist in neurodiversity. I'm a neurodiversity advocate, and this channel has a clear, unapologetic stance in defense of neurodiverse people. No BS, no virtue signaling. Just solid, honest content, grounded in science, lived experience, and real-world relevance. If you're tired of cliches and want strong, actionable ideas that challenge stigma, clarify concepts, and empower neurodivergent individuals and allies alike, you are in the right place. So we are now discussing the transition that exists, the gray zone that exists in between DBT, dialectical behavior therapy, and ACT, acceptance and commitment therapy, which are both third wave of CBT, cognitive behavior therapy. And in DBT, we have this concept, the skill of dialectical thinking, which teaches us that two concurrent thoughts we hold that seem contradictory might not be contradictory. So what we try to teach our clients is to say that instead of saying, I want to lose weight, but I'm overeating, which is the default understanding of how we would phrase that. We want them to phrase this as, I want to lose weight and I'm overeating, just to make sure we understand that it's just an apparent contradiction, but not a real contradiction. And in ACT, there is the idea that our mind is a chatterbox. Nonstop, it just chatters, not much of which matters. And I feel like Stephen Hayes, and also not just with ACT, but also within RFD, talks very much about this. I feel like this being your specialty, you should touch on this a bit.
Mm-hmm. So when we are talking about imposter phenomena or the way that we understand ourselves, we are always gonna use the resources from relational frame theory, which is RFT that you mentioned. That is our basic. It's the basis for our understanding of how we learn the things we learn about the world and the verbal behavioral learning.
We were talking about the narrative that we create and how that hinders the imposter syndrome later on in life.
Yeah.
When we need to get over the fact, the sunken cost bias, that you've considered yourself a lazy bum for the last 40 years, and now you have to change that understanding and say that, hey, I've always tried my best and I never managed because I was incapable of, let's try a psychostimulant.
So when you are dealing with acceptance, it's always a process, because everything that we learn, it takes longer to get into our coherent understanding of the world. So there's always this bias through which we see the world. We call this our internal coherence. This coherence is like a glue that will catch the things in the world that are most similar to the things that we've learned. So if I grow up with ADHD and I have this understanding that I'm lazy, right? This is a very common experience for us who have ADHD. So you're lazy, you are not motivated, you are just like a piece of shit. You'll be oriented towards noticing the things that you do that agree with this narrative that you're lazy. You were just saying that you could not remember if you were good or not in English back in high school, because when you were really little, you were told that you were bad at it. So you just bought it, know.
Right.
So you lived coherently with that. So your attention was towards noticing the things that you were not good at, not the things that you excelled in.
You end up even having a selection bias, right?
Exactly.
You discard the precedents, the events that prove the opposite, and you just accept the ones that prove your narrative.
Exactly. And this is the usual cognitive understanding of that, and we just give it a different name because we understand that it's built. It's something that happens with everyone, and everybody has their own coherence. So when we are talking about treatment, when we are talking about imposter phenomena, we have to talk to our clients through their coherent logic. Does it make sense? So if you tell Corey that is obviously a very smart person, that he's a very smart person, he will be like, you just think that because you don't know me. So I shouldn't give myself the chance to treat it because I've dealt with it so long, and maybe this is true for other people, but not me, because, and then he and I will try to find a coherent way to get out of it, because we might not think that we are worth the trouble.
Okay.
You know what I mean?
Mhm.
And it's my experience too. So when I give those examples, it's also always about myself as well. I'm just talking about Corey because it's easier.
No, please do.
No, I'm just kidding. So learning that we are worth the trouble is also something that has to come along with medication and coming over imposter phenomena and stuff like that. Because when we are neurodiverse, we learn that we don't quite fit. And because we don't quite fit and we have this belonging issue, it's really common for us to be like, maybe I would just be here, in the corner, not doing anything, not getting in anybody's ways, and just letting things run their course, not interfering, and just be here, be quiet, and forget that we are also active people in the world who, we are trying our best, that you were saying, right? Like all our behaviors are evolutionary peaks. So everything that we are, everything that we do was built to this point and worked for us at some point. And if we are if we are in therapy or if we are seeing our psychiatrist, it's because there is something that's not working and it's not as adaptive as it once was. So I would say, since we're here, let's give ourselves a chance to do something different and maybe build towards medication and building a better self-esteem and a healthier sense of self.
That's very compassionate. Let me use that to build on what I was going to talk about when comparing treating neurodiversity to treating obesity, as the narrative that we assume about ourselves, of lazy, defiant, whatever, not good kids, bad students. Neurodiversity is often, and other psychiatric disorders, all of them, are often understood as a lack of willpower or a flaw in character. And when we say, okay, you're lazy, that reflects on that. I want to use the analogy with obesity because I feel like obesity is very much changing nowadays because of the new level GLP-1 agonist drugs that show us very clearly that it was never about willpower. It's just because people were not set up to lose weight because of biological phenomena and homeostasis, and it never was about willpower, even though people might still believe, but I feel like that's in decline, but people might still believe that obesity is just a lack of willpower, or being lazy and not getting off the couch, which is another misconception because physical exercise doesn't really change that much about how much you eat, and your energy surplus might still be the same. But let's not dive too deep into this. But both of these conditions, neurodiversity and obesity, have historically been associated with a flaw in character. And this is about to change right now in terms of what we do for obesity. And I feel like people know, hopefully, yeah. But people are managing to be self-compassionate and to use medication that really will extend their lifespan. Going back a bit to the imposter syndrome / cheating misconception. Cheating would be like using a medication to treat neurodiversity, as would be cheating as in using a medication to treat obesity. In terms of obesity, it's pretty obvious that by using a GLP-1 agonist, we are actively improving our quality of life tremendously, and obviously expanding our lifespan. We'll have less cardiovascular disease, we'll have less cerebral disease, we'll have less Alzheimer's, less Parkinson, less alcoholism, less psychiatric disorders as well. And the very same is obviously true for neurodiversity. And I'm going to say it's the very same because it's also true for metabolic health. If we're treating neurodiversity, and let's say that your specific type of neurodiversity has the specific condition of eating disorders, it's pretty obvious how that also will apply to cardiovascular disease if you treat that eating disorder through treating the neurodiversity. So we're obviously treating and effectively treating all the major results of life through treating neurodiversity, but still, people still have the idea that maybe using GLP-1 is cheating, but they very much so do have the idea that using Vyvanse or Adderall is cheating, and that's just BS. So I do understand where people come from when they say, no, everybody has ADHD. And I do know that we do realize that the diagnosis of ADHD are increasing. But that doesn't mean it's not a valid diagnosis. It very much is. It's very much based on scientifically valid criteria, and it's very much based on how we can improve people's lives. So that really grinds my gears. But the other part is that if we use the stimulant, we actually end up improving total lifespan really clearly. So when people say, okay, I'm cheating by using a stimulant, I'm doping, or I'm gaining an edge, that's really not true. You're just trying to survive.
To get to know yourself when your organism is less stressed, like you regulate the dopamine and you have one thought at a time. The first time that I had a thought at a time because I took Ritalin, I was like, this is why people get things done.
Yes.
Like, there isn't a song like playing in the back while you're thinking about two things at a time and you don't finish those thoughts because they get entangled among themselves. Like, I can just like sit here and do that. What a peaceful world,
Yes. I had a recent example of that. I was talking to a friend online, and I don't take my medicine every day. If I know I don't need it for a day, like if it's a relaxed day, I don't take it. And I had a friend notice the difference in me as far as like responding, being present on social media and different things. And they were like, you're not sending random reels today. You're not doing this. I was like, oh yeah, because I took my medicine. I'm like focused on work.
I'm present in my own life.
Yes. I'm not doing 10 things at one time.
And it's one uncanny thing, like how everybody that I know that took stimulants like Ritalin or Vyvanse that has ADHD were like, but people take that to go to raves and stuff. Like, I'm just calm. How do people take that to get drugged and go all night? Like, I would never be able to do that. Yeah. Mm-hmm. One of my clients even his first thought, like the first hint that he got that he might be ADHD was because he tried cocaine and everybody was talking a lot and he was just like calm, just there listening, present, like being cute with his friends, and everybody was like talking their ears off, like, and yeah, that's insane. Yeah. How our body functions completely different, and we should listen to that. Like if your body doesn't produce insulin and you're diabetic, why wouldn't you take your medicine? Why do we do that to ourselves? And I think that there is social jeopardy, like surrounding stimulants overall, any type of stimulant for any reason. So there is this idea that we are drugging ourselves and we are going to get addicted to something that is bad and we shouldn't do it. And this is just measuring us with the rules of neurotypical people, and we shouldn't do that.
So just to a disclaimer that if you're thinking about treating your perceived ADHD with cocaine, please don't
do that. That's not what I'm saying.
There is safer options.
Yes, like Vyvanse.
Yeah, this is not a recommendation. I want to expand the conversation about the being diabetic and the insulin to other, and I want to make a point in saying accommodations that we use. You wouldn't judge a fish by its ability to climb a tree. You wouldn't judge a person that needs glasses by their ability to drive a car without glasses. You just shouldn't. There is no reason. Doesn't make any sense. And but the same is true for other accommodations that we use on a day-to-day basis. It's not specifically to neurodiversity. As we touched on the PDA podcast, we also role play all the time. It's not specific to PDA necessarily. And there's no issue with role playing. That doesn't make us childish or whatsoever. And that's also true for using Waze on your phone to find your way through rush hour traffic. That's also true for using a calculator. And maybe now you're going, hey, but when I was a kid, I really did do all those calculations in my head. And I do feel like I'm missing out on something through my accommodation. So that might not be the perfect accommodation for you because you feel like you're losing part of your narrative that, yeah, you were really good at math. I really strongly feel then when Waze came up that I kind of had to give up on my ability to navigate in Sao Paulo, which I was really proud of. But there's no reason for me not to use the accommodation because Waze is really, there's no way, and there's still some taxi drivers that believe that they're better than Waze. But there is no way. They don't have access to all the cell phone data that Google collects and puts into Waze. So I did understand that I had to give up on my special quality, my special.
But that's a choice, right? Like you could just turn it off, and if you memorize the Waze, you can still do it. But you choose to do it because you don't know how traffic is right now. So you want to track that as well, and you take those things into account, and then you choose to do that. When we don't give ourselves the chance to use one of our resources, we don't have a choice to make, right?
You have to understand that people are biased towards accommodations because they might not need that accommodation. So going back to the Waze thing, I really hated Waze because I was so proud of my ability of navigating Sao Paulo. But it wasn't too hard to give into that later on because, well, you start using it and I'm neophilic. I'm really curious about new stuff. So I really wanted to test Waze as well. And it was obviously superior to my reasoning 95% of the time, and that's enough for me of a reason to start using Waze.
Well, and you're talking about people who might not need certain help. Talking about weight, for example, you'll have a lot of fitness people talk about, oh, if you just do this, you work out, you're gonna be in shape, you're not gonna be obese, where they blame the obese person because they're not getting the same results as the other person. But there's so many factors, and medicine can help level the playing field. It's just everyone's different, and if you can have a tool, why not use the tool?
Yeah, and due to our punishment history, we don't want to be different. Mm-hmm. Right? This is why it's hard to accept that we might need accommodation. And again, we go towards acceptance. So accepting that we have different needs because we are neurodiverse is actually the thing that's going to enable all those other improvements that we've been talking about, getting treatment, taking your meds, accepting that your treatment in therapy is going to be different if you are autistic or ADHD in comparison with people that are neurotypical. But amongst neurotypical, we also tailor the therapeutic process to that individual person. That wouldn't be different because you are neurodiverse. But because we have this knowledge of what neurodiversity is, we already have scientific data that points us towards better or more promising ways of treatment that will work better for you, rather if you were a neurotypical person. So acceptance of our limitations is just accepting that we are humans, and this is not being different in a bad way. It's just being different. Does that make sense?
Yeah, and putting more point on the we are human thing. I mean, every human, different eye color, different hair color. We all have very different genetic makeup, different history, we have so many different experiences that shape who we are, that what works for one's not going to work for the other. So having the special tools or special types of therapy maybe, or different things, makes sense for everyone. You're going to have to cater everything, even the dosage of medicine.
Exactly.
You could have the same medicine for 100 people, but each of them is going to be on a different dosage. So you have to cater everything to a specific person.
Yes. Yeah.
We've touched on this before, but I feel like it's one of the things we want to defend here, that we need those labels right now. So we can just make sure we understand that we can self-advocate and advocate for people that have those labels. But in an ideal utopian world, again, we could just say, instead of saying, hi, I'm Tom and I'm autistic, I need this accommodation, I could just say, hi, I'm Tom, I function like this.
Yes, that would be so cool. It would be, because a lot of our lack of sense of belonging that leads to imposter syndrome comes from this idea that we don't fit. And if we just accept that, okay, we don't fit in that way, like you would not try to put a square shape on a circle hole, but if you try to put like in a different place, it might fit, you know? So also getting to know other people's neurodivergencies and learning how to navigate this world with people that are also like you, and you know, comparing those experiences and learning that, okay, it's okay for me to be a little weird, because that's just being me, you know, like we're here discussing a few points, and sometimes I'm going to interrupt and be interrupted, and that's fine because that's the way you function, and that's okay, and I'm accepted for that. That also helps with imposter phenomena and with self-esteem overall, you know.
We are all part of a lost generation of neurodiversity, and we all have been late diagnosed here. And that probably changed a bit about how we perceive our neurodiversity as well. But I want to take the treatment thing, the doping and the cheating, a bit on the other side by saying that I feel like you don't only should get adequate treatment, as I feel like you have the duty to do so, because it's pretty easy to see that if you grow up believing that you're not going to contribute anything, you're not going to contribute anything. And I'm not going to be ableist here and say that you need to contribute anything, but in terms of thinking as a society at large, if you get the right treatment, there is a much bigger chance of you to contribute. And I'm not saying that you have necessarily to have monetary rewards or whatever. You could just create a different kind of legacy, even through your loved ones. So touching back a bit on the thing I was saying about improving the life for you and your loved ones. Like if you're a hoarder and you start treating late, maybe your grandkids will still see the benefit and they will still understand who you really are and will make sense of your story, while your kids might still need some time to understand that you were just a different neurotype. One thing that I feel like will be helpful for anyone that's listening to our podcast here and is at the beginning of their journey, the fact that we're calling it a spectrum nowadays really makes a lot of sense. In psychiatry, there is a few distinctions for any disorders we use. So let's say depression used to have a bereavement exclusion that's really interesting. So we would, in the last DSM, always say that if you have lost a loved one within the last, I'm pretty sure it was 3 months. I'm going to look this up later, but I don't care because it's not relevant, and I'm going to show that it's not relevant. But that means that if you had lost someone you loved within a specific time period, you could not diagnose depression because of the bereavement exclusion. I do understand where that comes from. People will say, okay, it's normal to feel sad and low energy once you lose someone. But it's not fair to say that you're just going to let that person kill themselves because they have the bereavement exclusion. So you cannot diagnose them as depressed. So if you fall in whatever part of the spectrum, if you're suffering with anxiety, be that very little perceived anxiety, you still are entitled to treat. So I really don't care if you're 1% autistic or 99% autistic. If there is something you can gain from treating your autism, your neurodiversity, your learning style, if there's something you could self-advocate for, that you could accommodate for and ask for specifically, there is no doubt that you should do that. So this is why I'm always talking about the labeling that we use right now. And the labeling kind of makes it easier for us to invalidate our own diagnosis, and it makes it really easy for others to do so.
Yeah. And I just would like to emphasize that when we say treatment, we are not saying treating the neurodiversity so you look more neurotypical, right?
Yeah.
Like we are just trying to improve quality of life by regulating your hormones, giving you training with you, behavioral repertoire, so you can live the life that you want to live. You know, we are not trying to put anybody inside any boxes. We just want people to live as how can I say that? Sorry, it's coming in Portuguese in my mind, but we want to build our lives the most enriched way possible. And we do believe that medication and treatment can give you the resources to be the person, the version of yourself that you are most proud of. You know, that you can look at your day and be like, hey, this was a good day. And it wasn't a good day because you took the meds or didn't take the meds. It was a good day because you live the most coherent way possible to your values and the things that you want to be.
Yeah, it's kind of related to what I was saying earlier, where sometimes I do take medicine, sometimes I don't.
Exactly.
And the treatment isn't to make me one way all the time. It's to help when I need it.
Exactly. Yes. And maybe after taking the meds for a while and developing some repertoire, you can choose not to take the meds, or you can choose to take the meds, you know, but these are your choices based on your needs, based on what you want to work with. And it's amazing that we have these resources. Like I would never be able to finish my PhD the way that I did if I didn't take the meds. But also, like, I never took meds until I entered my PhD. And I wish I did. My life would have been so much easier. I wouldn't have had all those anxiety crises that I did have, you know, throughout the time that I was in college, like finishing up the college thesis. And trying to manage everything and trying to remember everything. It's crazy when you have ADHD to remember all the details. It's impossible, you know. And then when you take the meds, you are a little bit more detail oriented. That doesn't mean that you are a neurotypical person or that you work as a neurotypical person. It just means that because of the meds in that moment, you are able to orient towards those abilities that normally would be harder for you to do. It wouldn't be impossible, but it would be harder.
We also are not trying to change who you are. And
exactly.
You're not trying to change your values and your personality. And the meds don't do that anyway.
Yeah, thank God.
Yeah. But as is true as well for physical disease, if you're, let's say, a bit diabetic or a bit obese, and you can have a benefit from using a medication, why should you not use that? So I'm just saying, like, physical disease does usually have more clear cutoffs, but those are also pretty much just based on the way we need to study those. So what's the real difference between 3.1 insulin to a 3.2 insulin? That might change your HOMA score to being pre-diabetic, but that doesn't mean you really are very different. But if an intervention does make sense for you, you should still use it. I want to go back to the...
Can I just make another addendum? I don't know how is Corey's experience, but in my experience, taking the meds made me appreciate more the ADHD full version of me. Like when I don't take the meds, I kind of enjoy myself so much more.
Okay.
You know, I don't know, maybe it's because I've learned to like who I am with and without the meds.
I could see a similar situation. Is there are days where I want to be more creative and more relaxed also.
Yes.
And so those are days I don't take the medicine. And so I can appreciate that when I don't take the medicine, I know I'm going to be more related to this podcast. When I'm editing podcasts, I actually don't take the medicine. Even though it's a specific task that I have to focus on, I'm much more, I work better in the sense of if I'm editing, and then I could throw up other YouTube channels and like get inspiration or things. So I use the ADHD to help in that sense. Whereas a lot of people would say, oh, you have to focus on work. You should probably take medicine. It's like, no, actually, in that case, I'd much rather be the ADHD self versus the medicated ADHD version, which that's more for if I have a lot of students in one day and I have to focus on organizing English classes. I will take the medicine because I know I'm not trying to be creative in that. I'm trying to be more structural. So yeah, I embrace it, I think, a little bit better.
Yeah, for me, it's the same, exactly the same criteria. If I want to be more creative, I don't take it. If I want to be more structured, I take it. And actually, this took me a few months to learn how to be a good therapist after taking the med, because so much of the way that I thought the cases and the case conceptualization, everything, and being there present with my clients was so much easier without the meds. And when I started taking that, I noticed that I was just focusing on their speech and the things that they were saying rather than what they were expressing with their body, how I was feeling, what they were expressing, and all the analysis, everything that happened at the same time, but it's amazing that I learned to do that even when I was medicated, so we don't lose this ability. We don't lose our ADHD, our essence, our ADHD selves. We just regulate it differently.
And being present is a interesting idea there too. If I'm in a class with the medication, I am much more present in what the person is saying directly, like word from word, accent, everything. But if I'm not on the medication and I have class, I'm much quicker to remember and relate things that they're saying now to things they've told me in the past.
Yes, that's my experience too.
You don't necessarily need to make peace with your past. You don't necessarily need to reframe who you are. You don't need to change all your narratives, but at least it gives you a chance to reconnect to how you function nowadays.
And one thing related to the obesity and medicine thing and what we're talking about just now, when people take medication for physical characteristics, there's usually not a regret afterwards. They don't regret losing the weight. They don't regret having stable insulin levels and things. That's usually there's a positive outcome and people are happy that it happened. But with neurodiversity, with more psychiatric medicines, that was one thing you and I talked about a lot when I was first starting my medication was, do you regret not having that medication your entire life up until now? And I think I was fortunate that I didn't have a lot of regrets, but it seems to be something that people do go through, is that they look back and go, oh, I wish I had it earlier.
You never know what you might have become. That's, to me, the hardest part is the fear I have from trying to reframe what happened in the past and kind of forgive the bullies and the idiots and the abusers. And I really don't want to do that because I strongly feel that those were the idiots, the bullies, and the abusers. So that was the hardest part for me to understand. Okay, maybe my neurodiversity caused that back then, but it's really not true. It really doesn't have to matter if I were neurotypical and neurodiverse back then. It really doesn't change anything about who was at fault.
But if this were a physical thing, you wouldn't have that. You would just be like, oh, I'm fine that I'm changed now. Thank you for watching. Please subscribe and get notified when our next episode drops.